Stephanie Hutter-Thomas is the Research Program Director for the West Virginia University Research Corporation's BIRCH study and an educator and consultant for the Maryland Rural Opioid Technical Assistance Program, MarylandROTA, through the University of Maryland Extension. Since 2016, Stephanie has served the Western Maryland region as a researcher, community educator, and harm reduction advocate, addressing stigma, mental health, literacy, and promoting peer support services. She is actively involved in multiple community action groups, including Healing Allegheny Consortium, the Stand Together Garrett Coalition, and the Allegheny Community College Community Resilience Collaborative. As a mental health first aid instructor, she has provided over 65 workshops since becoming an instructor in 2018, certifying more than 500 mental health first aiders. We are incredibly excited to have Dr. Hutter-Thomas join us today as she shares with us the foundational knowledge of the nation and statewide opioid crisis and the multifaceted solutions that the state and our communities can implement to reduce the impact of this health crisis. Please join me in giving a warm welcome to instructor, advocate, and dearest cat mom, Dr. Stephanie Hutter-Thomas.
Thank you. I love the dearest cat mom addition to my credentials there. I love that. Thank you. So just a little plug about MarylandROTA before I jump into this. So MarylandROTA stands for the Maryland Rural Opioid Technical Assistance Program, and it is a fairly newer program through the University of Maryland Extension. And basically, it's funded by SAMHSA, and it aims to strengthen the capacity of rural Maryland communities using a multi-pronged approach, which includes evidence-based trainings and the dissemination of information, and a component that specifically focuses on life skill development for youth. Because one thing that we do know when we're talking about things like the opioid crisis and healing communities, certainly, we need to run damage control for the things that have already happened. But if we want to change things moving forward, we've got to look at what we're providing for our youth. We've got to look at what protective measures are we putting in place for young people so that they are less impacted by adverse childhood experiences and therefore less likely to develop serious mental health challenges or substance use disorders later in life. So, and I wanted to kind of plug that because I think it's really important for people to sort of think of it in a spectrum like that. There's multiple ways here that we're going to tackle this and heal our communities. There's not a singular answer here. And we'll hit on some of that as we work through the curriculum. So I won't get into, doing any kind of lengthy intro for myself since Leah already did it so well. So we're going to jump right into the material. The Opioid Public Health Crisis course was developed by Overdose Lifeline Incorporated, and it's an Indiana nonprofit organization that's working to reduce the effects of the opioid epidemic through education and prevention and harm reduction, as well as treatment and recovery services. The organization was essentially born, through the heartache of a mother who had, experienced a child, spiraling in opioid addiction. And so that to me kind of gave it that much more weight, which is why we chose to adopt this curriculum through MarylandROTA. So the presentation is going to focus on opioids, but it's important to note that while opioids are the cause of the current public health crisis, this is cyclical in nature. Historically, other drugs have held this designation, and it's very likely that that's going to happen in the future. So right now it's opiates, but next year or a few years from now, it could be, heavily swinging towards something else. Right now, we're seeing a lot of polysubstance use. So, it wouldn't shock me if, 2 years down the road, rather than a heavy focus on opiates, it's, specifically on polysubstance use or, another substance altogether that is kind of, taken the lead title. So before we kind of dive into opiates, we're going to talk about some drug classifications. Drugs are categorized or classified according to certain shared symptoms or effects that they have on our bodies. So, depressants obviously slow the activity of the central nervous system, and types of drugs that fall into this category would be things like alcohol, barbiturates, benzodiazepines. And if you don't know what benzodiazepines are, think of brand name medications like Xanax, Ativan, Klonopin, Valium. These drugs are all prescribed, pretty freely. And, but it's important to note that with benzodiazepines, they affect the brain very similar to the way that alcohol does. So, just kind of keep that in your hat for future reference. Then we get to cannabinoids, and this includes hashish and marijuana, and then hallucinogens or psychedelics, which include things like mushrooms, LSD, ketamine, PCP, and peyote. Then that brings us to inhalants, which are things that are sniffed or huffed and typically include common household items like cleaning fluids, gasoline, glue, spray paint, anything along those lines that has fumes. And then we get to stimulants. Stimulants speed up the body's nervous system. And so the types of drugs that fall into this category would be amphetamines like Adderall, for example. But then we also have illegal stimulants like methamphetamines and crack and cocaine and ecstasy. And of course, we cannot forget that even the more socially acceptable things or the things that are considered legal, like caffeine and nicotine, for example, fall into the stimulant category. Then, of course, that lands us on narcotics. This is where we're talking about opioids and opioid-based medications. And when we're talking about prescription opioids, we're talking about things like Percocet, hydrocodone, and Vicodin. When we're talking about illicit opioids, we're talking about things like heroin and illicitly made fentanyl. Then that very last category there, new psychoactive substances, or abbreviated as NPS. This includes a wide range of drugs that have essentially been designed to mimic the effects of illicit drugs. So basically, these are substances that are meant to sort of mimic the effects of cocaine, of ecstasy, LSD, or marijuana. And the thing here is, the people creating these have gotten pretty smart, right? So they mess with the chemical structure and alter it in such a way that they manage to avoid illicit drug laws. And they're constantly changing to stay ahead of new laws. So, eventually the powers that be will figure it out, crack down on it, or there'll be some sort of an incident relating to one of these substances that draws attention to it. And then boom, the manufacturers are, altering it one more time, to stay ahead of the game so that it doesn't fall under, the illicit drug laws. And so things that fall into this category would be things like, bath salts, that we hear about, or like herbal highs and, designer drugs. So now that you have that little bit, of a background on classification, let's get into the topic of addiction and substance use disorder. So the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM-5, is by the American Psychiatric Association, also known as the APA, and it characterizes all substance-related addictions as substance use disorders, or abbreviated as SUD. The most severe form of SUD is addiction. So for the purposes of this course, we're going to primarily use the term addiction, just to kind of clarify the terminology a little bit. So, addiction or substance use disorder is not a choice. It's not due to a lack of willpower. Addiction is a chronic brain disease that can be compared to other chronic diseases like diabetes and heart disease and high blood pressure. And, when you think about chronic disease, every chronic disease impacts, specific organs, in the body. So when we're talking about addiction, it's the brain that is the organ that is impacted. And, we know that chronic diseases generally, can't be prevented by vaccines, nor do they just go away on their own. However, with appropriate treatment, often including medication, many chronic diseases can be managed such that their symptoms, no longer impact a person's health and functioning. So, at one time, we used to think of addiction as this moral failing, but now there's this growing body of research showing that there are differences, between people who use substances versus those who develop a substance use disorder or addiction. You know, and this is a really hard point that I'm always trying to drive home to people when I'm out in the community, you know, delivering these types of trainings, is I'm trying to help people understand that using substances, even using substances regularly, does not automatically equate to something problematic for a person. So we need to kind of shed that black and white, all or nothing kind of idea. You know, a person can be mentally dependent on something, you know, like, for example, really enjoying your glass of wine in the evening, you know, or that person, for example, who uses medical marijuana and, you know, just has certain times of day that they're really all about their marijuana use. That doesn't necessarily mean that the person has an addiction. Addiction suggests that a much more severe turning point has occurred within the brain, leading to other consequences. And we'll kind of break some of that down as we go through this. So we know that addiction changes both the brain structure and its function. So what actually starts as a choice, because, you know, we hear that a lot out in the community, right? Why should I feel bad? They chose to do this. They knew it was bad for them. They knew they could overdose. Well, something that starts as a choice, you know, very quickly becomes hardwired in the brain as being critical for our survival. Right. So this is why people will often, you know, once they're, you know, caught up in the disease of addiction, will often, you know, ignore, you know, responsibilities and things that once meant so much to them. You know, and people will sit back and go, I don't understand. I don't understand. Well, you're not going to understand, because the addiction has affected that person's brain and changed the hierarchy of survival in their brain. So, you know, the number one thing now is satisfying the addictive urge. Everything else is secondary, including children, eating, sleeping, working, all these things. Okay, so, you know, just keep that in mind too, that there's something very significant that happens in the brain that leads to the poor decisions that come after, you know, an addiction develops. So how many Americans are affected? Well, you know, there's an estimated 20 million Americans right now, you know, at any given time, that are symptomatic, meaning that their disease of addiction is active. They're in active drug use. And then, you know, add to that, there's another 23 million that are actually non-symptomatic and they're living in some form of recovery. And so, you know, what does that mean? Well, that means that 43 million Americans are impacted by addiction. So, I mean, this is not something that we can just choose to, you know, not concern ourselves with. I mean, you know, I don't care who you are or what, you know, field you work in, or, you know, what neighborhood you live in. You know, everybody should be paying attention to this because it's pretty devastating. So, despite these high numbers, only 1 in 10 people with addiction actually receive treatment. And, you know, this treatment gap really, you know, leaves millions without proper care. And, you know, we know that there are a great deal of treatment barriers, you know, so let's talk about those for a moment. You know, treatment barriers like availability of treatment programs. Certain areas, particularly the more rural areas, you know, have a shortage of, you know, these sorts of facilities and programs that will offer treatment. And, you know, then we have the high cost, right? There are many people out there that simply cannot afford the costs that come with it, or, you know, don't know how to navigate the Medicaid system in order to get approval, you know, or because of family obligations and things like that, it's very difficult to try to figure out, you know, how to go into treatment, you know, when you have children at home and things of that nature, you know, just a lot of complexities here. And then of course we have, you know, travel time for outpatient treatment programs. I know up here in Western Maryland where I'm at, now there's been some improvements, but, you know, just to give you an example, there's some rural pockets here where it would take someone a $60 cab ride every day just to get to and from, you know, the clinic to receive a dosage of methadone. And even if you reduce that to once a month for Suboxone treatment, still, you know, someone who's impoverished having to pay, you know, 60 to 80 bucks to get into town to get their medication, like that's pretty devastating. So we have to think about all of these things, you know, and the barriers that they present. So now let's do, kind of an overview of opioids, because a lot of people get really confused by the term opioids and are never really quite sure what falls into that category and, what makes the different types of opiates, unique from one another. So first we'll say opioids do have a legitimate medical use. So, in the process of this, we have to be really careful about, demonizing the use of pain drugs, because try to imagine a world where, you're in a horrible car accident and, you're dealing with some pretty severe injuries and you get to the hospital and they can't give you anything to give you pain relief at that time. That would be a really stressful and traumatic and horrible thing if we were to completely remove opiates as an option. They do have a legitimate medical use. However, because they also have a high potential for addiction and misuse and overdose, and because people can build a tolerance to them very quickly, they're generally not recommended to be used for long term. They were never really intended to be used for long term, but it's just sort of happened that way. And we'll kind of touch on that a little bit moving forward too. But there are an estimated 36 million people worldwide that are misusing opioids. And the use of opioids, might not be quite as widespread as the use of cannabis, but, definitely is considered a major drug of potential harm and health consequences, we all know. 9 million Americans reported that they use prescription opioids non-medically. And that third bullet point there is one of my favorites. America represents only 5% of the global population. However, we consume approximately 80% of the global opioid supply. Global. Wrap your head around that for a minute. It's just crazy. And, as many as 1 in 4 people who receive prescription opioids long-term for non-cancer pain in primary care settings now struggle with addiction. So as far as the family of opioids go, they all differ in how they're made and in their level of potency. So for example, morphine and codeine are natural opioids originating from the poppy plant. Then, we get to heroin and oxycodone and Vicodin and Percocet. And, there's some others that we could add to that list. They're considered semi-synthetic. So, part natural, part laboratory created. And then we have the fully synthetic category. And this is where fentanyl and methadone fall in. So, we talk about fentanyl a lot. And I think at this point, most people know that fentanyl has a very high potency. Fentanyl is generally 50 to 100 times more potent than morphine. Okay. And remember, morphine's a natural opiate. Opioids obviously are manufactured by pharmaceutical companies, but what a lot of people don't realize is how many opioids are actually manufactured illicitly, including pills and fentanyl. So regardless of the form, opioids can be addictive due to their chemical makeup and the overall effects on the brain. So it really doesn't matter, which of these categories they fall in. They're all addictive, but, how addictive they are, how potent they are, and, even I think a bit of the withdrawal process and everything is going to be impacted by the type of opioid that, the person is using the most. So prescription opioids can be used to treat moderate to severe pain and are often prescribed following surgery or some kind of, accident or injury. And for health conditions like cancer. But, what started to happen was there was a dramatic increase in the acceptance and use of prescription opioids for the treatment of chronic non-cancer pain, so like back pain, osteoarthritis, things like that, despite serious risks and lack of evidence about their long-term effectiveness. So, anyone who takes prescription opioids can become addicted to them at some point. And everyone who takes opioids long enough will become physically dependent. Physical dependency and addiction are two different things, and that's generally reserved for a completely different training, but just, kind of keep that in your hat as well. A person can become physically dependent on a drug if they take it long enough, but it doesn't necessarily mean that they are now disordered. The disorder part is when we start adding on issues relating to consequences and not taking them as directed and things of that nature. So here is an expansive list of opioids, and this will be in the slide deck handout that I provided in the Google Drive. So you guys will have this, for later reference. But, just kind of giving you some names of the different opioids that fall into these different categories. So, of course, under natural, we see codeine, morphine, and opium. And then under semi-synthetic, if you notice, you see buprenorphine, which is one of the medications used to treat someone with an opioid use disorder. And if you notice methadone, which is another medication used to treat opioid use disorder, it's fully synthetic. So a little bit of a difference there between those two drugs. Doesn't mean that one is better than the other at treating the symptoms of the addiction. It just, basically means that where one might work better for one person, the other might work better for somebody else. So yeah, you can see there, even carfentanil, we started hearing talk about that, when fentanyl hit the streets, we started hearing about carfentanil, and, that's used for large mammals. And again, that falls into the synthetic realm as well. And of course, we've all seen, the news and trends that are constantly, bombarding us about illicit fentanyl. And, I just want to stress there's fentanyl that you can get, through the pharmacy that is prescribed by a doctor, usually in patch form. And it's often prescribed for people who have such severe levels of pain that other opiates aren't working, or, maybe someone with a cancer diagnosis, someone who's terminally ill, etc. The fentanyl that we're hearing about, causing all these overdoses and taking people's lives is, typically the illicitly made fentanyl, right? So what we're seeing are counterfeit pills being made out, on the streets illicitly, and they're typically, pressed heroin and or fentanyl, often a combination product of some type, or it might be fentanyl and then some filler or something. And it's pressed and usually stamped to look like a name brand Xanax or OxyContin. And so this makes purchasing prescription pills on the street that much more dangerous, because a lot of people are purchasing these pills thinking that they're just buying someone's unwanted prescription, when, they're really buying something that is completely different than what they thought, and they're experiencing, overdose situations. So now let's get into a little bit of data and, kind of putting some of this in perspective for everyone. So we'll start out talking about, some more of the national data, but then we're going to kind of filter down into what's been happening in Maryland. So we absolutely know that, the U.S. is in the midst of an opioid public health crisis, and it's affecting most American states. And the truth of the matter is it's crossing, socioeconomic and ethnic groups. Like there's no boundaries here. It's crossing over into all sectors of the population. From 1999 to 2018, which was the most recent reporting that came from the CDC, more than 760,000 people have died from a drug overdose. 2018 was the first year to see a bit of a decrease since 1999. Drug overdose deaths decreased by about 4.6% between 2017 and 2018. Now we know since COVID has happened that what good we were doing and that little bit of a reduction we were seeing has pretty much been reversed, which is sad. It just shows you, how fragile recovery can be. But you'll see that in the Maryland stats here in a minute. But looking at, what we're seeing here still, more than 67,000 people died from drug overdoses in 2018, which made it the leading cause of injury-related death in the United States. So drug overdose is also the leading cause of accidental death. In fact, overdose is the leading cause of death for Americans under 50. In 2018, more than 67,000 Americans died from a drug overdose, and this is more deaths than from car crashes, guns, and homicides or suicides. So, top of the food chain here is, opioid overdose death. So basically opioids account for about 70% of all overdose deaths. And of those overdose deaths statistics we were talking about a moment ago from 2018, 47,000 of those deaths were from opiates directly. So, in America, you're more likely to die from an opioid overdose than from a car accident or a gun, is the simplest way to summarize that. So, to summarize, the involvement of opioids, basically 2 out of 3 deaths involve an opioid, 2 out of 3. And so here from 99 to 2018, nearly 450,000 Americans died specifically from an opioid overdose. And, there's a growing body of evidence to suggest that opioid overdose deaths are actually underreported. 1/5 to 1/4 of death certificates don't actually identify a specific drug. It might just say an overdose and, not a lot more. And this is unfortunate because, we're underestimating, the role of the involved drug, and it can add to some additional errors. So just keep in mind that as you're hearing about these numbers, they're conservative. As high as these numbers sound, I mean, they're actually conservative because it is underreported. So most every state in America is affected. And so, this map is a 2018 CDC map. And basically it's showing, the overdose age adjusted rates for kind of like a view across America. And the darker the blue, the greater the overdose rate. So look where we are, we're right in here, we're right in this dark blue area. So our region is more heavily impacted, than anywhere else in the country. And so here in 2018, the states that had the highest rates of death due to drug overdose were West Virginia, Delaware, Maryland, Pennsylvania, Ohio, and New Hampshire. And then for 14 other states, and including the District of Columbia as well, the drug overdose death rate was lower in 2018 than 2017. Most specifically, Alaska, DC, Florida, Georgia, Indiana, Iowa, Kentucky, Maine, Minnesota, New York, North Carolina, Ohio, Pennsylvania, West Virginia, and Wisconsin. And then here, the drug overdose death rate was higher in 2018 than in 2017 for California, Delaware, Missouri, New Jersey, and South Carolina. And, you can hop on the CDC's website at any time and look at their data. They are a bit slow in putting out the new stuff. Like I said, I still don't think they have anything up for 2019, let alone the stuff related to or in alignment with COVID. But, when we get into some of the Maryland information here in a minute, the good news is you'll see much more current. So here, this is again, CDC information, and, we're going to kind of show you a little graphic representation of the 3 waves, that really fed into the opioid epidemic. So wave 1 began in the 90s, and this was with increased opioid prescribing and overdose deaths due to prescription opioids continuing to increase. And this went on for more than 18 years before kind of flattening out a little bit around 2017. And this was also the time frame, when OxyContin started to, really rise up and was being falsely marketed as non-addictive and, could be prescribed to absolutely anybody to get rid of their pain. If you haven't watched the series on television called Dope Sick, it's based on the book. It's a fantastic dramatization of the real events that occurred that kind of brought us here. So I definitely suggest that for later viewing if you have the time. So then we move to the second wave, because all these overdose deaths started happening because of prescriptions. So then right away, new regulations and, tightening up those bootstraps and, trying to kind of intercept and stop that. The problem is when you intercept and you stop something without providing any kind of a relief mechanism for the people that are already caught up in the cycle, you're pretty much inviting black market and underground, organized crime stuff. You're just inviting that stuff in. You really are, if you're not providing a relief mechanism. So that's what we're seeing in wave 2. The second wave began in 2010 with heroin access increasing. And so, people weren't able to get pills anymore. A lot of people were getting their prescriptions cut, or doctors' offices were shutting down. So now all of a sudden you had people that were, strongly addicted to opiates and had no way of, obtaining what they needed to feel well. And so naturally they're going to turn to heroin. So then naturally, in the world of organized crime, suddenly all of the gangs and the cartels start to see that there's a huge demand and opportunity for business growth. So this is where we see a lot of gang infiltration happening in small rural areas, where it's, kind of unexpected. Because, well, like here in Appalachia, it was referred to in Baltimore City as money in the mountains, because, drug dealers could come from Baltimore City and come up here into Appalachia and sell a bump of heroin for double the price that they would get in their urban neighborhoods. So that's wave 2. And then right around 2013, we start seeing significant increases in overdose deaths involving synthetic opioids, specifically fentanyl. Okay. And, again, like I mentioned earlier, most of the increases in fentanyl deaths over the last 3 years don't involve actual legitimate prescriptions of fentanyl. They typically involve illicitly made fentanyl that was acquired on the street, typically in the form of a counterfeit pill or something, or sometimes it's mixed with heroin, sometimes it's mixed with cocaine. And sometimes the person who's going to use the drug, doesn't even know that the fentanyl's in there. Sometimes they do. That's kind of up in the air, but this is how we got here. And if you look into, things like the iron law of prohibition and whatnot, you can completely make sense of why these 3 waves happened the way that they did. Definitely encourage that for later reading. So, news coverage and, social media and, all the various platforms out there, really get caught up in talking about heroin and fentanyl when they're reporting on overdose rates, which, is important because it's a real threat. But one thing we don't want to lose sight of is we want to continue to raise awareness to how dangerous prescription opioids can be when they're not used properly. Because there's a lot of folks out there that look at it like, prescription opioids good, street opioids bad. And really, they all do the same things, and they all pose very similar risks. So we kind of got to get out of that thinking. We don't want to pass that on to our youth and have our youth thinking that abusing a prescription drug is not nearly as scary as an illicit drug. And here's why, because right there where that little black circle just popped up, in 2018, the number of overdoses due to prescription opioids was almost equal to the number of overdoses due to heroin. So again, kind of squashing that notion that, someone who's using heroin is in much more danger than someone who's, taking too many pills or snorting pills or what have you. So very similar in, the effects over time. Opioid involvement in cocaine and psychostimulants and benzodiazepines is actually pretty substantial. Opioids are involved in about 74% of cocaine overdoses, and about 50% of psychostimulant overdoses, and about 85% of benzodiazepine overdoses. And, this could be for a multitude of reasons. This could be because of purchasing contaminated product on the street rather than getting, a benzo prescription legitimately from a doctor or something. It could be because the person is intentionally using 2 different substances at the same time, or it could be because the substance that they purchased on the street was just simply contaminated with fentanyl. So now let's talk Maryland a little bit here, because I'll tell you what, I think most of us that work in this field, we're pretty emotional over COVID, over what was happening, with the opioid crisis in our state. So as shown here, you can see in 2019, we actually started to make very minimal progress. But as you can see, our number, was slightly lower in 2019, and then COVID hit, and here we are. It was worse than it was before the pandemic. As far as unintentional intoxication, fatalities, concerning all substances, okay, not just opiates. And this was pulled from the Opioid Operational Command Center's annual report. So, you can look that up anytime and, kind of keep up to speed with what's going on. So as shown here in this figure, there was 2,499 opioid related intoxication fatalities in 2020 in Maryland, which is an 18.7% increase as compared to 2019. And opioids were involved in 90.1% of all fatal overdoses, which is higher than any other point during the opioid crisis. And in this figure here, it's kind of showing, intoxication death by opioid type. And, the most important thing for you to notice here is the fentanyl line, and look how it has basically surpassed everything. We've even been seeing a decrease in deaths related to heroin, because fentanyl has pretty much replaced heroin, for the most part out on, the street market, from what most of us are finding out through our research and our interactions with people who are still in active drug use. We're finding out that, everything out there now is fentanyl, fentanyl, fentanyl. So there was also significant increases in the number of unintentional intoxication fatalities involving non-opioids in 2020. There were 917 cocaine-related deaths, which is a 5.5% increase from 2019. And you can kind of take a look at this yourself, just to kind of, process that. These are non-opioids, but they're deaths that involve mixing these substances with opioids. So for example, somebody has, an opioid use disorder, so they're taking opiates every single day, but then maybe recreationally, they will occasionally, also use cocaine simultaneously while using heroin. They call those speedballs. Sometimes if someone is experiencing some withdrawal and feeling ill because they're struggling with finding, a drug supply on the street that they can purchase, or they don't have the money, individuals will often turn to things that they can access, such as alcohol, So as you can see, there's a lot of poly substance use really kind of taking over. And this here is a per county breakdown in the state of Maryland for opioid related intoxication deaths. And now, they've started to put out the 2021 numbers. I'm waiting for the full annual report before I update all of this. But in 2020, it was quite devastating. I'm in Allegheny County, so it's the first one that you see there. And we experienced 108.7% increase in overdose death in 2020. And if you look, you can see the majority of the counties did experience an increase. There was a couple that showed, let's see, I think there was like 4 altogether that showed a bit of a decrease. But we can't get too excited about that, because this next slide shows regionally in the state of Maryland, every single region in 2020 experienced a hike in overdose deaths related to opiates. So Maryland was hit pretty hard during COVID with the opioid crisis. So now let's kind of get into talking a bit about things that contributed to all of this, things that contribute to addiction, and what some of the risk factors are. So opioid prescribing practices are a primary contributor to the misuse and to the health crisis. Between 91 and the prescribing rate peak of 2012, opioid prescriptions more than tripled, with 255 million prescriptions dispensed at a rate of 81 prescriptions per 100 people. Since 2012, prescribing rates have slowly started to decline. So the CDC 2018 prescribing rate report found that healthcare providers wrote 168 million prescriptions for pain medication in 2018. The national prescribing rate had fallen at that point to the lowest it had been in more than 10 years at 54.1 prescriptions per 100 people. However, prescribing rates for opioids vary widely across different states and counties. So, it's really dependent on locality. So for the state of Maryland, for every 100 people, 45 pain medication prescriptions were written. States that had the highest opioid prescribing rates were Alabama, Arkansas, Tennessee, Mississippi, and Louisiana. And the lowest prescribing rates were Minnesota, California, New York, Hawaii, and Washington, D.C. And, again, each state's prescribing practices vary. Today, states are working to educate healthcare professionals through academic detailing to bring them up to speed on new opioid prescribing guidelines that were issued by the CDC in 2016, as well as initiatives to improve prescribing data recording to help address the overprescribing practices of the past. So one of the key contributors to the increased use of opioids for non-cancer treatment was due to a 1980 New England Journal of Medicine letter to the editor, believe it or not. This letter to the editor was cited hundreds of times by doctors, academics, and pharmaceutical companies as evidence that few users would develop addictions to opioids. And of course, it was very misleading. It was false information. And, later this letter was retracted. And then, of course, we have things like marketing to physicians and incentives for prescribing. And then, of course, direct to consumer advertising of opioids may have also helped to encourage this. I'm 49 years old, and I often, talk about how when I was growing up, you didn't see targeted television commercials advertising name brand drugs left and right. You didn't. It just wasn't really a thing. If you wanted to know about name brand drugs, you went and you talked to your doctor about your symptoms, and your physician then would bring you up to speed on what was available to you. But now, we see typical, advertising techniques and deception used to market drugs, legally on our televisions and our billboards and things of that nature. So I definitely think, it's logical to assume that it may have, played a role in all of this. And so today, the medical community is undergoing that retraining I was mentioning and education to update the knowledge base regarding addiction and its intersection with short and long-term pain management care. So here, it's listing out some of the main contributors. So like, for example, prescription drug misuse, the misuse of prescription opioids puts one at risk for addiction. And we live in a culture in America where, I don't think, until the opioid crisis, anybody really talked about how serious it is to be responsible and take the instructions on your prescription drugs seriously. Think about it. How many of us grew up in a household where, you got some penicillin for a sinus infection or something that was going on with you. And as soon as you started to feel better, you stopped taking the antibiotic, right? But you never threw it away. You threw it in a drawer because, well, it's gold and you might need that at some point. What if my tooth hurts? What if I get this, that, or the other? I get an infection. What if I get a cold? So we would do stuff like that. And I really don't know why. I don't know if we were all just afraid that, there's suddenly going to be a shortage of antibiotics or what, but, we've all kind of been conditioned to, not necessarily want to go and throw prescription drugs away when we're not using them. And or sharing pills with somebody. Think how many times that, someone may have had, a pain pill in their purse and very innocently, not even, as a recreational thing, but very innocently, a friend is like, oh man, I threw my back out last night. Okay, well here, would you like one of my pain pills? People do that stuff all the time without even really, connecting the dots that this is a form of prescription drug misuse. Even if it's not, intended to be a recreational thing. And then we have culture and society. As a culture, Americans perceive a higher rate of pain than other countries, which is why we consume 80% of the, opioid global supply. And, there's a paper in 2017 that actually found that Americans appear to be in greater pain than other countries. 34% of the study participants reported experiencing frequent chronic pain. And then, of course, there was the issue of viewing pain as a vital sign in hospitals. In the 90s, pain was added to blood pressure, pulse, temperature, and respiration as the 5th vital sign. And, many of us, might even remember a time of going, to the emergency room for something and, encountering this. The problem here is that pain is not something you can just easily measure. It's not like taking someone's blood pressure or doing a blood draw and running a few lab tests. Pain is a self-disclosure thing, and it's very subjective. And everyone's pain tolerances are different. Their interpretation of pain is different. So, really, really short-sighted, when that rule was put into play, making pain one of the vital signs. In 2016, the American Medical Association actually voted to remove pain as a vital sign for that very reason, because it just simply cannot be objectively measured. Then we have healthcare incentives. So in the past, hospitals and practices actually received incentives and reimbursements based on how well they managed the patient's pain, because, well, remember, pain was a vital sign, right? So, they were recording a person's self-reported pain level. So then, ultimately in their evaluations, after they've received healthcare services, they were asked, how's your pain level? How was your pain level when you left? And if they rated it high, those providers would, get incentives and reimbursements, in various forms of kickbacks. And this really helped to encourage liberal pain medicine prescribing practices. And then beginning in 2018, the federal government announced that it would not pay out financial rewards to hospitals that did a better job at pain reduction. They said no more of this. And then, of course, we have dosage and duration. The higher dosage and the longer someone is on opioids, the more likely they are to develop a substance use disorder, and the more challenging it can be to treat and overcome. So, how does prescription opioid addiction relate to heroin use? Well, rarely does anyone just start off right out of the gate as going straight to heroin. 4 out of 5 new heroin users actually started out misusing prescription pain pills. So, that's a very strong pathway. When we started seeing more prescribing happening and, we started seeing more of it hitting the streets or just being readily available in people's houses, we started seeing more people getting careless with them. Then suddenly those pills were taken away. Now, all of a sudden you have a whole bunch of people, trying to figure out how to function day to day, in light of their new addiction. So, a lot of people turn to heroin because of the cost too. Prescription pain drugs on the street, their value is very, very high. Like, we're talking anywhere from $60 to $80 a pill. So now imagine if you're a person that needs 4 to 5 pills a day, and just do the math on that. Like, nobody can afford that. But heroin's cheap. You're going to pay about, I don't know, $5 to $15, depending per bump. So, it makes complete sense why people would turn to that. 94% of respondents in a 2014 survey of people in treatment for opioid addiction said that they chose to use heroin because prescription opioids were just far more expensive and harder to obtain. So, prescription opioid addiction affects many individuals across our society. So it's not just teenagers, it's not just middle-agers, it's not just one ethnicity or race or, one class or segment of people. It's absolutely anyone. I mean, it can be, the 39-year-old with back pain, or, the grandma who was prescribed opioids after a fall or a surgery, and it can even be the 15-year-old searching through their family or friends or grandparents' medicine cabinet. In fact, for young adults and youth, those who misuse prescription drugs as high school seniors, the mean age of first use was 15. And this appears to be related to the perception that experimenting with prescription medication carries a lower risk and therefore is more socially acceptable than purchasing illicit drugs on the street. And most young people do initially get them from their family and friends' medicine cabinets because, at one time, nobody talked about the need for locking these drugs up, if you were prescribed them. And of course, now, we know better. In 2018, there was a study out of the University of Michigan that found that opioids after wisdom teeth removal nearly tripled the risk of long-term use. So, researchers recommend that dentists and oral surgeons consider prescribing non-opioid painkillers first, like some kind of, strong ibuprofen or something like that. And then if that isn't enough, prescribing less than 7-day opioid supply recommended by the American Dental Association. So, basically what we're saying here is, in America, by automatically prescribing opioid pain drugs to every teenager and young adult that's having this very common surgery, done on their teeth, we are essentially flipping the switches of addiction on in people's brains. I mean, that's what we're doing. Other countries, they don't do this. For example, all throughout Europe, most countries in Europe do not prescribe opioids so readily, especially to young people after something like wisdom tooth removal. They do tell people to go home and take some Tylenol or take some ibuprofen and call us if it gets too severe. So there's something to be said for that. So this chart here, I'm not going to go through every single one of these because it's going to be in your handout that you can download. But, this chart provides some signs of heroin or prescription opioid misuse. There are certain things that kind of are telltale signs that kind of carry across all people. Physical signs like lack of hygiene or track marks on the arms or covering the arms with sleeves, is definitely something. And I really want to say, when we're talking about injection drug use, don't get hung up on the idea that it has to be in the arms, because more often than not, people move on, kind of rapidly from injecting into the arms to doing things like injecting into their ankles, their neck, their wrist, their hand, pretty much anywhere that a vein can be found. And I'm noticing it seems like there are more and more who use IV drugs and inject in places that are less visible, under the clothing and things like that. Health signs like weight loss or changes in appetite or sleep, very severe chronic constipation is a big sign. Opioids are also used to treat things like dysentery because it locks up the bowel. And so when someone is misusing opioids, they tend to really struggle with their digestion in that regard, and definitely a telltale sign. Behaviors such as, nodding off or, losing friends that they had for a long time, loss of interest in activities or hobbies. And then there's signs like you might notice around the house, things like missing money, missing valuables, checks disappearing out of the checkbook, randomly finding pawn slips and things like that laying around. And then also, of course, signs of paraphernalia, like missing spoons or finding spoons or aluminum foil that look burnt, like as if they were burned with a lighter or a flame, that sort of thing. So now let's get into a little bit about recognizing and preventing overdose, just to touch on it. So people who get opioids from multiple sources are at high risk of overdose naturally, but, that's not the only thing. I mean, children who accidentally take them, elderly people who are prescribed opioids and forget, that they already took their medication, so they take it again. People who are taking opioids who also have, some kind of respiratory problem, or if they're already taking some sort of, other respiratory depressant like alcohol or benzodiazepines. So, there's lots of things that put you at high risk. And I mean, really anybody that's taking opioids for, any significant period of time on a regular basis, the longer it's going on, the higher the risk. So what does an opioid overdose look like? Basically, face is pale, clamminess to the touch, the body tends to be limp, blue fingernails, blue or purple lips, vomiting, gurgling noises, not responding, can't be awakened or is unable to speak, and either the breathing and or, the heartbeat slows or stops. Now, in an incident like this, obviously we're going to, quickly call 911. And I hope that everybody on this call is trained in naloxone. And if you're not, I strongly urge you to reach out to your local health department or harm reduction program and get yourself a free naloxone kit and carry it with you, because you never know when you may be called upon to save a life. And, I think that everybody should be equipped at this point, because here's the thing, if you witness an overdose, tossing someone in the shower isn't going to bring them out of it. You see that stuff in the movies and whatnot. Throwing someone in a, cold bath or, putting ice on their face, things like this, that's not going to change what's happening. So don't waste your time with such things, and don't risk creating, more issues or a greater health emergency by, doing some of that crazy stuff. Like, just stick with call 911. And if you got naloxone, administer it right then and there while you're waiting on help to arrive. So that brings us to the topic then of naloxone, also known as Narcan. So if you're not familiar, naloxone is basically an opioid antidote. It reverses an opioid overdose. And, while the mechanics differ, you can think of it, similar in concept as, say, like an EpiPen. It's reversing a reaction that someone's having. When a person is overdosing from an opioid, their central nervous system and respiratory system is depressed and breathing slows or stops. But naloxone actually will kick all the opioids right off the receptors very quickly. And it blocks the effects then of the opioids and reverses that overdose, allowing the victim to breathe normally. And now keep in mind the effects of this overdose antidote is not permanent. So what does that mean? Well, that means if someone has used a lot of opioids and you manage to revive them with naloxone, you have about 60 to 90 minutes roughly to get them, in an ambulance or get, medical care on the scene. Otherwise, that person could very well fall back into an overdose state as the naloxone, wears off. So it's not a permanent antidote. It buys you time. It also cannot be used to get high, and it's non-addictive, and it's not harmful, if it's used on someone who doesn't have opioids in their system. Because we get that question a lot, like, what if I see someone that appears to be, unconscious or passed out, but what if it's like, diabetic related or a heart attack or something like that? And we always say, when in doubt, administer it, because it literally takes seconds to do. And if it is an opioid, you're going to pull them out. And I believe that that's kind of how EMS generally views it as well at this point. So, naloxone can be administered through, a variety of devices, but the one that we are most commonly used to seeing on a community level are the intranasal bottles. And each one is a single use pump. So typically an naloxone kit that you get from like harm reduction or something, or the health department, is going to have 2 of these in it, enough for 2 dosages, because with the fentanyl being what it is out on the streets, sometimes it does take a couple of doses, to pull somebody out of an overdose state. Now, the intravenous version is typically what's given in the hospital in severe situations. And, also the intramuscular injections and whatnot. So, you get a lot of saltiness out in the community about people just not being happy about, naloxone being offered. And I know a lot of it too is ignorance. A lot of it is a lack of understanding about what it actually does. Because I really do think there's a lot of community members out there that think naloxone is in and of itself an opioid and like it gets people high or something. And it doesn't. It doesn't do any of those things. So I always like having that opportunity to make sure I'm spreading the word and clarifying. So making naloxone available does not encourage people to go out and use more. This is one one of the popular, myths out there, that it's all about, get so high you overdose and then someone revives you. And then you go back out and party. And it's like, people clearly don't understand what the drug market's like if they think that, because someone's not going to go drop, a chunk of money on some really good drugs, get high, and intentionally overdose just so they can be revived and go out and spend more money on drugs. Like that doesn't make sense. It's not a pleasant experience when someone is revived with naloxone. It's not like they wake up and they're ready to hit the streets and do it again. They often feel absolutely awful because we just threw them into total withdrawal. Naloxone acts as a bridge between the call to 911 and when help arrives to keep the person breathing. And again, no effects on someone who is not suffering an opioid overdose. And again, you might need to do a repeat dosage if no response after 2 to 3 minutes. And as with any other medication, there's going to be some storage rules and an expiration date on the packaging. Now, more currently, they've reformulated naloxone to where it can handle some extreme temperatures much better now than the way it used to be. It wasn't recommended to like keep it in your glove box or anything like that because of extreme temperatures, but that has since changed. And that was intentional, so that more people would have it readily available. Naloxone laws in every state will differ. Maryland's been on the forefront in their efforts to address naloxone access. And since before 2015, there's been a statewide standing order that allows pharmacists to dispense naloxone without a written prescription. So anybody can walk into a pharmacy and acquire naloxone, but you're going to have to pay for it, which is why I typically tell people, go to your health department or reach out to a local harm reduction program, because chances are they have grant funding that has allowed them to purchase this to distribute to the community. So, it's going to save you the money that you would pay for it in the pharmacy. And so now in this final section here, we're going to talk about best practices and solutions. So, what you see here on this slide, represents, the things that we know work. These are strategies that we know will work. This health crisis might seem insurmountable, but I mean, there really is hope. Communities across the country have been organizing and, activating and mobilizing and applying all these different practices and solutions, based on the unique characteristics of their community. And that's kind of how we have to view this, because every community is very unique. So we know that these strategies work, but we know that, they work best when we include people from all sectors, public health, private, healthcare, law enforcement, etc. And so I'm going to touch briefly on each one of these. So prevention education programs, if we begin them in grade school and continue throughout the school years, really help to address the age-specific risk factors that can lead to misuse and addiction. And then in addition to youth-focused prevention, parents and other community stakeholders, such as, healthcare workers, businesses, educators, and just general community members, should all be educated to the potential misuse of opioids and the risk factors and suggested prevention and reduction methods. When we deploy this kind of education and information across entire communities or states, the result is that all of the stakeholders are carrying that same level of awareness and the same knowledge level, which improves cross-channel collaboration and overall results. So then we have safe prescribing guidelines. So the CDC has mentioned changed the prescribing guidelines in 2016, and while these new guidelines aren't a requirement, a lot of states have been changing their laws and policies to help combat the opioid health crisis and align prescribing rules and laws with these suggested guidelines from the CDC. So provider recommendations from the CDC are to, start out with non-opioid therapies first, and, non-opioid pharmaceuticals such as anti-inflammatories. So things like physical therapy, exercise, cognitive behavioral therapy, etc. And, start slow and low, right? So if you have to give somebody opioids as a physician, start with the lowest dosage and be very slow to increase that dosage, see how it's, going to impact the person's situation, and, stop at the lowest dosage possible. If it's deemed that extended release is the best option, because they're really suggesting that most physicians get away from that extended release thing too, and do more immediate release, because the extended release medications definitely serve to help contribute to what was going on, because once people began to crush the extended release medications and use them outside of their directed instructions, then what was happening was people were getting that full dosage of the opioid rather than getting it over the course of 24 hours or 12 hours or whatever. They were getting it all at once, and so it was increasing the rate at which people became addicted. So, but they're saying if you absolutely have to do extended release, to meet a patient's needs, aim for those that are abuse deterrent. And basically, this is where Big Pharma has attempted to develop some, medications that are extended release, but in a form that makes it harder to crush, snort, or inject. Now, personally, and this part's opinion, an informed opinion from the work that I do out there. But I will say a lot of these abuse deterrent opioids aren't so abuse deterrent, because at the end of the day, where there's a will, there's a way. Addiction often equates to some pretty severe desperation when it comes to behavior. And so, I've seen and heard just about everything. So I'm always a little bit leery to assume that any of these could be, abuse resistant, because I've seen the creativity that can happen out on the street. So then from the patient side of things, the CDC recommends that, everybody start being more educated consumers of healthcare, period. Stop just blindly accepting what medical providers are telling us and ask questions, be informed, ask your physician if they're following the CDC guidelines. And, if they try to prescribe you opioids, ask first, like, is that really necessary? Is there other types of therapies, things that I can do to address my discomfort? And always keep those lines of communication open. So it's important to remove and dispose of unused prescriptions as well. So as I was mentioning before, a lot of young people tend to get their hands on prescriptions that have been left lying around. And think about how many people had a terminally ill, family member, like a grandparent or something that moved into the home, for their final months or years or whatever of their life. And they were ill, and, you ended up with a drawer full of medications, and then that family member passed away. And now there's this whole giant, drawer or box of prescription drugs. So many people have this going on in their house. And it's unfortunate because it really does, provide a mode for younger people to get their hands on them. And it also, provides an opportunity for theft as well. So we strongly encourage that everyone find the medication disposal sites nearby, and make sure that anything that you're not using that you have in your medicine cabinet gets safely disposed of. Don't put it down the toilet or down the sink drain, because that contaminates the water supply. If your community does not have some kind of a drug take back program or a disposal box, somewhere convenient, you can actually take pain medication and put it in coffee grounds and add water, like in a baggie, and just shake it up, wait about 30 minutes and just throw the whole baggie in the trash, and it will ruin the drugs and deactivate their effects. So improved reporting and data access regarding opioid prescribing and overdose rates and participation is a critical element in, this multifaceted solution approach. So, a lot of people get angry about this because they think they're being policed, because of all the people, with a substance use disorder, now they're struggling with their own chronic illness because medications and stuff have been restricted. But we need to look at this from like a different perspective and look at this as this is helping to keep physicians in check, and make sure that, nobody is operating in a shady way. There's no pill mills open anymore. That's kind of the purpose of this. It's more to monitor the behavior of the prescribers than anything else, to make sure that, they're following, local rules and, not over prescribing or taking advantage of patients. So early intervention is critical for addressing any kind of substance misuse problems or mild disorders, and to help prevent the development of more severe substance use disorders. So for example, if you catch something early, and you're able to intervene, then generally the intervention doesn't have to be nearly as intense, than something that's been ignored and has gone on for far too long. But primary care physicians and schools are great points for early screening for young people. And by talking about the disease of addiction and educating others and choosing words that don't further stigmatize this chronic disease, we can help remove or lower the barriers for someone getting help. And, it really just comes down to words matter, and continued use of stigmatizing language really just perpetuates false stereotypes. It spreads misinformation, and it keeps people out of treatment, plain and simple. So, we've got to find ways to, adjust the way we talk about this, out there, and learn to be, hold space for people, I guess would be the best way of saying it. So as the anti-stigma toolkit says, addiction doesn't define who a person is, it describes what a person has. A person's addiction represents only a part of that person's life, and defining people exclusively by their addiction diminishes the wholeness of their lives. So, when we're talking about this, we want to call it what it is, a substance use disorder, and get away from, saying things like junkie, or so-and-so's an addict. We want to kind of steer away from that and use, person-centered language and, try to use more proper terminology. For example, we get away from things like saying clean or dirty, and instead, we'll say that a person had a positive or negative drug screen, or, they're in active use, or they're in recovery, rather than saying clean or dirty. And then harm reduction. We know harm reduction works, and for those who aren't all that familiar, harm reduction is a range of public health policies and solutions that are designed to reduce the harmful consequences that are associated with various human behaviors, both legal and illegal. It's all about meeting a person where they are and not leaving them there, and when you think about it, we've been using harm reduction across the board for a very long time, sunscreen, bike helmets, seat belts, airbags, all of these things are harm reduction. So, when we're talking about opioid harm reduction, this is where we're talking about things like naloxone and fentanyl test strips, so people can test their drug supply before they use and know what they're about to put in their bodies. Medication for addiction treatment, is a big form of harm reduction, because it stabilizes people, so that they can start rebuilding their life until they finally have built a life that they don't feel they need to escape from. And syringe exchange programs, people get really, up in arms over syringe exchange programs, but I tell you what, people in active drug use who subscribe to syringe programs are 5 times more likely to enter treatment and 3.5 times more likely to stop injecting and switch to a safer mode of use. So we know these programs work. They also work to significantly reduce disease, and they build trusting relationships between the person who's impacted and public health and other volunteers, which can help break down barriers, when that person's ready for more. So it's important to treat addiction as the chronic disease that it is, through accessible, clinically proven approaches to treatment and continuing care and recovery support. A full continuum of treatment includes things like intervention, detox, inpatient rehabilitation, outpatient treatment, and intensive outpatient, as well as family and codependency treatment. So, it's very much an individual journey. Not everybody goes through recovery the same way. For some folks, it's about going into an inpatient program and then completely abstaining for the rest of their life. For other folks, it's about, having a brief period of no substance use and then returning to some sort of managed use. For some folks, it's going right to a medication that stabilizes their use so that they no longer need to use drugs on the street. So different for everybody. And it's really important that we ultimately respect that and support people. It's basically whatever works, as long as it's, safe. So across America, often there is limited access to clinically proven treatment and recovery services, with less than 10% of the people seeking treatment actually able to access it. But in many states and communities, there are active initiatives underway to increase the number of trained professionals and collaboration with primary care physicians for screening and referrals. In fact, my position with WVU School of Medicine, I'm directing a study, and that's essentially what we're doing is we're working to get more medications for opioid use disorder into primary care settings. So that individuals with opioid use disorder can go to one place and really start to dig into all of their health needs, while also having their use disorder managed. So I want to leave you with some lasting thoughts here. If many people in many places do many little things, we can change the effects of this health crisis. It seems like a lot, but if we all, contribute in our own little way and our own little communities, over time, we are making a difference, and we will continue to make a difference. Some of the things that you can do, raising awareness and education, share what you learned with your family and friends to help, educate others and elevate that awareness. When you hear or see or interact with someone with addiction, choose empathy instead of judgment. Help to change the language surrounding addiction by using stigma-free words and helping your friends and family learn how to do the same. If you or a family member is prescribed opioids, manage your prescription and dispose of the unused medication safely and promptly when you're finished. And if you see a suspected overdose, don't delay, call 911 to get the person help, and, get trained in naloxone and start carrying it with you, because you never know when you might have the opportunity to save someone's life. And at the end of the day, you got to be alive and breathing to recover, right? So thank you all very, very much. I'm going to stop my screen share so I can see people in front of me. Here we go. And I'm happy to answer any questions you might have before we close out.